Good morning and welcome to our peripheral intervention symposium today. Good morning from New York, I should say, or anywhere you may be around the world. I'm George Dangas, and with me I have my co-moderator Vishal Kapoor.
Good morning, everyone.
And we have a very interesting case, but before we go to the cath lab, let me tell you a few things that if it's the first time you come to this website, the www.peripheраlinterventions.org, you can communicate with us during the case, and you can send us an email at info@peripheраlinterventions.org, and we'll be happy to discuss it either ourselves here in the moderators, or we kick it off to the operators, or we incorporate in the discussion. The website in the archives has all the past cases, including the one we did in August, and obviously it will also have this one a few hours from just now. Also, I would like to say that on the October 9th, on Friday, we will have a live symposium here at Mount Sinai regarding the top 10 events of clinical cardiology. So it's not strictly interventional. I think it borders imaging, clinical cardiology, and everything else. Finally, there is an app, and you can go to the App Store and look for the Apple App Store, and you look for CCVVC, and this is our symposium, annual symposium app that you can download, and you can interact and view what happened in the past symposium of both coronary, vascular, and valvular cases. So the App Store, you look for CCVVC. Anyhow, this is great. Vishal, any other housekeeping remarks, or should we go ahead?
We'll just move into the cath lab. We just changed the menu of the presentation today, and we're going to discuss a very interesting venous case. We'll let Dr. Krishnan take over. Morning, Dr. Krishnan.
Good morning, guys. Again, thank you so much. I mean, we're waiting on Dr. Guja. This is Dr. Guja's patient, so he's stuck in traffic. You know, New York traffic is ridiculous. But what we have a wonderful case to present, and we're just getting things ready. I'm going to have our fellow Dr. Sachin, who is actually over there, start the presentation right now.
Oh, great. Sachin, go ahead.
Good morning, everybody. We have a very interesting case today. We are switching gear to venous system today. So the chief complaint of the patient is a 42-year-old male presenting with bilateral lower extremity swelling for a few years.
Sure.
Going back to the medical history, in 2010, he was found to have a chronic venous insufficiency. So he underwent bilateral great saphenous vein ablation because there was a reflux, and that was done at outside hospital. So he felt better for some while, and then in 2013 he was found to have a bilateral iliac vein acute DVT that was treated with Coumadin therapy for 6 months, and then everything, he felt better, but again he started having this leg swelling. That's why he's here. Currently he's not on any medications. Physical exams, he has bilateral lower extremity swelling with the skin changes. CEAP classification would be class 4 here. And lower extremity venous duplex ultrasound was done in the office, found to have a bilateral external iliac vein chronic DVT. There is no acute component. We cannot be sure that, but it looks like more chronic. And all other deep venous system were compressible, doesn't have any DVT. Without respiratory phasic variation, that signifies that there is an outflow problem and significant deep venous reflexes. Both of his great saphenous veins were absent because they were been ablated. So we ordered a MRV, venous magnetic resonance angiogram, that showed a similar finding but without any abdominal or pelvic pathology. This is a still image showing with the arrow you can see that there is a bilateral iliac, external iliac vein compression. The plan today is do a IVUS, guided bilateral iliac stenting. Back to PK.
Well, thank you. That was a great presentation, and you know, it's actually a very interesting case, as Dr. Sachin went over with you guys. Dr. Jain went over. This is a patient, a very young man, who's been suffering with this, has had venous ulceration, so on and so forth. You know, I took a good detailed history from him. It's interesting. He's never said, he hasn't noticed one inciting event in his life, but he says that you know, this is obviously the edema and the swelling has been bothering him. And Dr. Guja, who when he gets here, will go over a little bit more of why he decided to do the MR venogram, diagnose this. But I want to show you guys some important stuff, George and Vishal. Go scene minus. So I want to show you the importance of just on one side of what we're seeing. Minus again. Minus one more. So you can see here that it's bilateral stenosis, right, of the veins. So here we have bilateral 11 French sheath access into the vein. And what we decided to do was compare and contrast the importance of intravascular ultrasound to really talk about the compression. So here right now we're doing a venogram through our right common femoral vein through the 10 French sheath. And here you can see an obvious stenosis, right? So fine. So here you can say, okay, this is part of the reason why this problem is happening. Go next, please. And then on the opposite side, we went and did an injection bilaterally. And here you don't see anything, but what I want you to notice, and I think it's important to notice, is the contours of the iliac vein, or the common iliac vein. You see that the right common iliac vein looks like, for lack of a better terminology, a circular tubular structure on a two-dimensional view. The left looks even larger, but in fact it's a pancake. It's been flattened. Now, generally speaking, an inexperienced operator will look at this and say, okay, well, it's a dilated iliac vein, I'm done. But in reality, this is the problem. Both of these are the problems, but it's a great illustration of how you can get fooled by what I call angiographic lies. So what we did was we put an intravascular ultrasound. I'm going to do a live run, and I'm going to ask our technician to measure and stop at the spots of concern. So we're live on IVUS now. Go to my live run, right? So I'm going to take it all the way up to ensure that I'm in the IVC, right? Where's the tip? Let's go even further up. So now, okay, so guys, when you look at the intravascular ultrasound, we are inside the inferior vena cava now. So you see the vena cava is never fully circular. You know, it's a large thing, but you can see the catheter is inside the inferior vena cava. We know we're below the veins. So as you're coming down with the IVUS, I'm going to do it both on fluoro as well as on what is it called? IVUS, excuse me. You can see here as we're pulling down, you're going to start to see the artery come over the vein, okay? So now notice where the catheter is, okay? As we come down, there's your artery, right? And as we keep coming down, now you notice the compression of the vein. You see that, guys?
Yeah.
You see the actual compression of the vein with the artery.
So that's
okay?
a May-Turner syndrome, no?
Well, this is May-Turner's, which is interesting, George, because the initial presentation is that in MR, this was just called bilateral iliac vein stenosis. Nobody talked about this as May-Turner's, and honestly, I don't think Dr. Guja suspected this either. So as you come down further, right, as you keep coming down further, now you can see the artery and the vein separate again.
Yeah, and we can see now right here. So can you see where you are? Because over here the vein is very good.
Right, so right now, George,
we go to angio?
you can see.
Oh, you're on angio. Okay, I can see that.
You
yes.
can see both, right?
Yes,
so,
yes,
so,
okay.
so now I'm going to go forward again, and you know, I'm going to go forward one more time, right? And then you can see
here it starts to become.
it's starting to get the compression, George. You see that?
Yeah.
Yes.
And then as we go further up, okay, now you're going to see right there, you start to see the artery, and then you got the IVC. You see that?
Yeah,
This
so
is a
essentially
classic.
we got to go from the fifth. I mean, the compressions happen from the fifth lumbar,
Right,
and down.
And I'm going to come, but you know, this
for
is the
about
kind
a
of thing.
vertebra and a half.
This is the kind of thing that is very interesting for us because, you know, I'm going to do IVUS on the other side. So I think this illustrates the importance of angiogram. Or, you know what I'm going to try here? I'm going to try to.
Okay, there's something I wanted to tell you. There was a question of whether there is the external iliac vein might be compressed a little bit on the left side. So it was exactly what your sheath was finishing. So maybe you could IVUS this and pull the sheath back a little bit to clarify that.
I'm going to do that right now. I'm just get this wire up since I have it in my hand. I'm just going to shoot this wire up. All right, good. Now I'm going to go back in with the IVUS here. Guys, what's our ACT? Thank you. I'm going to go back in with the IVUS here. I'm going to pull our sheath back just the way George is asking. Okay? And I'm going to go right there. So there you go. There's the
Right.
There's the artery in the vein. As you keep coming here.
It's just a natural taper.
I think it's just a natural progression here.
Now in the
Yeah.
sheet.
Yeah, I don't think it's major. Now I'm in the sheath.
No, it's true, but you know, given the fact that there was also another stenosis on the other side, a little bit a little bit distally to the common iliac, you know, that's a good thing. That's a good use of IVUS.
And I'm going to show you on the other side, and I'm going to do one more thing as well. Flush this, please. I'm going to do a lateral angiogram. Let me do a lateral angiogram to see whether we can show the compression. Because one of the things is, put me back on DSA, guys. 234. Give another 500. Actually, yeah, you can give 1,000 because it's going to be a long case. Come forward, guys, with some dye. Sir, I want you to take a deep breath in. Let it all the way out, sir. Don't move, don't breathe, don't swallow. Oh, you can swallow.
It's carotid.
So you can sort of see it a little bit better here. You almost like you have to imagine it, but I'm going to freeze it on the spot where you can see the compression. You see that right there, guys? Let me go back. You see that right there? So you see the compression, the dent in the artery,
And then the
and then you see the IVC above. And we're going to do a bilateral shot now to show you in this view. Maybe that'll be better. Actually, let me put my my power injector on this side. Come forward, please.
So Dr. Dangus, just based on looking on this imaging, do you think it's bilateral May-Turner or is just two different etiologies playing at the same time?
I think it may be two different.
Come
Let's
forward.
look at the right side.
Keep coming more. So George, the interesting thing is Dr. Jane has done a lot of work here trying to elucidate this for our audience and talk about the different ways. But let me just take one more picture, and then I'm going to go to his lecture, and then we're going to do the IVUS, because the case itself is my inject. See right there? So that's where we know it was happening. So the point is, let's go to the lecture here, because he's got about 8 slides on this very difficult topic to understand, which is deep venous stenting, and then we're going to come back to you guys. So go ahead, go to the lecture, and I'll just take another IVUS. Okay.
Thanks, PK. So today I have a short presentation of iliac vein compression syndromes. Quickly going over the etiology, 25% of the American adult population suffer from some sort of lower extremity venous abnormality. And the cost of treatment is about $1 million per year, and the economic burden, including loss of work days and other morbidities, is cost up to $2 to $3 billion, and it estimated is just only next to upper respiratory tract infections. About 500,000 new DVTs are diagnosed every year in America, and 50% developed post-thrombotic syndrome after first DVT if not treated appropriately. So what is the anatomic influence of the iliac vein? This is very important here. 25% of people have some degree of iliac vein compression as a normal variant, which is like more than 50% compression of the iliac vein by the artery. And iliac vein compression syndrome is the most probable cause of iliofemoral DVT, and 1/4 of all the DVTs we see is a iliofemoral DVT. So 60% of the patient with the left-sided iliofemoral DVT, which we are talking about the May-Turner and its variant, have intraluminal webs or spurs. That's because of the chronic extrinsic compression of the left iliac vein by the right common iliac artery. So the most common is a left common iliac vein being compressed by the right common iliac artery. And up to 5% of these patients will suffer from chronic deep venous insufficiency of the left leg. So quickly going over the etiology, it can be acute or chronic, and we just quickly went over what is May-Turner syndrome or its variant, which I have another slide I'll show you. But we have to rule out the other rare causes too. That's why the imaging plays an important role in the screening of these patients. We have to rule out any pelvic malignancy, any trauma, any surgical complications or catheterization complication, or the patient has received any radiation therapy in the past. So what are the variant of May-Turner syndrome? The most common or the usual pattern is the left common iliac vein being compressed by the right common iliac artery. This is a little bit confusing, that's why I highlighted with a different color. So the other variant is a left iliac vein being compressed by the left iliac artery, or the left iliac vein being compressed by the left internal iliac artery, or the right side. Very frequently, very rarely there have been some case reports where the right side is also affected. Right iliac vein compressed by the right common or internal iliac artery, and there has been a case report of the right iliac vein being compressed by the left common iliac artery with the patient with the left sided IVC. So physical examination is important, the first stage. The patient usually comes with the swelling, we see the skin changes. There is a way to classify these, mostly applicable in a reflex, but we can also use in this the CEAP classification, which is a clinical, etiological, anatomical and pathophysiology. The most commonly used is the first part of the CEAP, which is C, where we classify patients from C1 through C6, starting from a small varicosities to the skin ulcerations. And there is another scoring system called venous clinical severity score, which is used to determine the outcomes of therapy. There are like 10 variables there, starting with the symptoms, the findings, ulcer and compression therapy, mostly applicable to reflex, but we can also use in this case to see how the patient improve as far as clinically too. Diagnostic test is very, very important. Ultrasound duplex with the color flow plays a very, very important role. That is the first test always performed, but it's difficult to image the iliac veins. But in our case, we still saw there was some chronic changes in the common iliac veins with ultrasound itself. The next test is either CT scan or MRI. So in CT scan, you will be able to diagnose 75% of the times, but 25% of the times there may be a false reading, because the fibrotic changes in the vein may obscure the underlying structures and we will not be able to image. MRI is a very, very I would say the non-invasive gold standard test. It's underutilized. It depicts the area of compression or obstruction. It documents the presence of collaterals. Sometimes it's very rarely may not be able to visualize few segments of the vein because of the turbulent flow, but still it's good. And as you know, the gold standard is the invasive venography as our patients is undergoing. So what are the additional tools we may have which will help us with the diagnosis? As you were seeing, IVUS play a bigger role. Greater than 50% reduction in the cross-sectional area is a significant one. Sometimes people recommend doing a pressure gradient, but it's a very minimal pressure gradient, so it will be difficult to appreciate. Difference greater than 2 millimeter of mercury at rest or 3 millimeter of mercury with exercise, or on a pullback again 2 millimeter of mercury gradient is considered significant. When to suspect iliac vein compression syndrome? Any patient who has a chronic left lower extremity symptoms, very, very rarely right side, and persistent symptoms despite anticoagulation. And who are the patients who need intervention? Any mechanical cause of DVT like pelvic mass or May-Turner, or young patient with acute iliofemoral or very proximal femoral DVT, extensive thrombus burden extending into IVC, propagation of DVT or persistent symptoms despite anticoagulation. So what are the goals of treatment? Acutely we want to prevent PE, restoration of venous return and prevention of recurrence. Chronically to prevent post-thrombotic syndrome, prevent ulcers, improve quality of life and prevent venous claudication. So what are the treatment options we have in these cases? Anticoagulation, yes, but the recanalization with that is very, very poor. So we can use thrombolysis, systemic or catheter directed thrombolysis. Mechanical we have angiojet, or pharmacomechanical like trellis, and also catheter director we can have either ECOS catheter or a plain catheter to just locally infuse TPA. Balloon angioplasty alone is substandard. Stenting, wall stents are better than the nitinol stents, wall stent made by Boston Scientific, because of they are made of alloy and they have a better radial strength, and follow-up anticoagulation and antiplatelet therapy as appropriate for the patient. So I just want to go over 3 quick guidelines here for and against use of IVC filter. So contraindications to anticoagulation, patient may need IVC filter. Resume anticoagulation when contraindication and bleeding resolves, that's the time to retrieve the filter. Filter should be periodically evaluated for removal, and recurrent PE despite therapeutic anticoagulation. And if you see, I put in a red there, IVC filter should not be used for routine treatment for iliofemoral DVT, because filter come with its own complication. There have been 2 to 5% rate of having a major complication with IVC filter removal. This is one study from 2005, it's called PREPIC study. the beneficial effects of IVC filters to prevent recurrent PE in patient with DVT at high risk for PE were offset by an increased incidence of recurrent DVT with no effect on overall mortality. So this is a 3 graphs from the study where you see that with filters you decrease the rate of PE, but there is more recurrent DVT, and if you see overall the filter does not offer any survival benefit on these patients. So what is the guideline for and against use of thrombolysis in iliofemoral DVT? Catheter directed thrombolysis is considered first line treatment for patient with acute DVT to prevent post thrombotic syndrome in selected patients who are at low risk of bleeding complications, patient with the leg plegmasia cerula dolens, the leg changes, or patient has a rapid thrombus extension despite anticoagulation. Again, if you see for against, I put in the red letters there. Systemic lysis should not be used routinely for iliofemoral DVT, and chronic DVT more than 21 days or at patient has a high risk for bleeding complications. What is the guidelines for stenting? If there is any obstructive lesions, yes, it's mandatory to stent because without that the outflow will not improve. The placement of iliac vein stents to reduce post thrombotic syndrome and heal venous ulcer even in advanced PTS and iliac vein obstruction is reasonable because that will improve the outflow and patient may benefit from that. So putting everything in a nutshell, my conclusion would be there is a need for relief of mechanical obstruction. Rule out secondary causes. MRV is a great tool, magnetic resonance venogram, PTA stenting plus or minus thrombolysis, follow-up anticoagulation, and no need for routine use of IVC filter. And that's my presentation. Thank you very much.
Well,
Back to PK.
That was really excellent.
That was great.
You know, and George,
Dr. Guja has joined us. Welcome, Dr. Guja.
I'm sorry, Dr. Dagan.
PK was saying something though.
so he actually has arrived. We're just teasing, but you know, it's interesting. So now what we did while we were offline, while that we were getting that presentation, is to show you the IVUS of the right external iliac vein. So can our IVUS team please start just the run without any measurements? So we're going to start the run from the beginning, please, not from the end. The run from yep, thank you. So you can see here we're in the inferior vena cava, pulling back, and you can see as he talked about, the overriding is not as prominent here at all. Actually, there is none. You can see the vein and the artery together here, and then you could start to see it's not really compression. I don't want you guys to get fooled. This is not compression at all. Now, as you see, there seems to be some tubular flattening of the vein, and then you can you'll see that as we pull out into the sheath, that was it. So this is a different morphology. If the question is this iliac stenosis, is this iliac vein stenosis from chronic scarring from DVT, or is this now is this something we should treat, or is this something we should leave alone? So this begs another argument, and I think this is kind of the reason why we were suspecting this, and we wanted to put this as a case to you guys. So we have two, in my opinion, we have different problems going on. One is May-Thurner syndrome of the left iliac vein, and then on the right, it's either a tubular stenosis of the vein because of chronic DVT and scarring, or is it just a flattened vein? So what we decided to do, we asked our IVUS team to start with the right. So what they did was they measured the reference vessel proximal to this tubular stenosis and distal. Since we know the patient has, and Dr. Guja, please correct me wrong if I'm wrong, has bilateral symptoms, then so the point is this significant enough to cause a problem? So here you can see what our team has done is go to the other measurement that you showed me with the compression of the right. So you can see here you have compression of the vein here, and show me the reference vessel overlapped.
Not this.
There was one that showed 50%, right, or no?
The proximal.
Well, it's a little difficult to know where the vessel is. It looks to me that the vessel is actually pretty circular, and this is indeed sort of compressed.
Right, but the question is, George, do we treat this or not? Because I think that's the challenge,
Well,
right?
if it has recurrent problems,
That's
clinically
the
you will
IVC.
tell me if there's a problem in the right leg or not. In the left leg, we have a good reason with a May-Thurner. On the right leg, what's the problem?
Well, that's the question. So let's this is exactly what we were talking
Let's
when
see
we
if
were,
Dr. Guja
when we
has
were
any
offline. Dr.
information
Guja,
about
what's the
that
issue with
once
the
he,
right leg?
So,
you know.
so Dr. Dangus, I mean, I know him for I think about 6 weeks now. So I think he has. So his story was he has chronic venous insufficiency symptoms, and he had ablations done 3 years ago. I think he persists to have the bilateral chronic venous insufficiency symptoms.
ACT.
I did an ultrasound, and on the ultrasound, I found right iliac vein, kind of external iliac vein thrombosis, chronic, looked like on the ultrasound. So I did an MRV. On the MRV, we saw this bilateral iliac vein stenosis. That's what I thought. I didn't realize that there would be a compression syndrome on the right, on the left side. I was thinking it's probably bilateral chronic iliac vein stenosis from the thrombus. So he has bilateral symptoms. I mean, it looks like it's probably compression syndrome, May-Turner on the left, but this iliac vein stenosis angiographically looks significant. As PK said, there is no compression, but like we can see here, we are right on the 50% mark, and because of his insufficiency symptoms, there is a lot of data which says that before treating the superficial veins, you want to treat the deep veins, iliac veins, if to treat the insufficiency, if they have significant insufficiency.
So I think this is interesting because, you know, this is a borderline call in my opinion, because you've got on the left you've got no question. I mean, I think, you know, this is compression, this is May-Turner's, you've proven it. On the right, the teaching, George, as you and I both know, is about in the veins about 50% stenosis generally becomes significant. But the question is, are his symptoms severe enough on the right to say that it's because of this and stent this? Stenting it is not the problem. The problem is whether or not we should stent it.
No, there's another question though. If you stent the May-Turner, aren't you going to create a stenosis on the right? And because there's already some kind of a stenosis on the right or some problem, does treating the May-Turner going to require you to just stent both anyhow?
But why do you say that, George? Because you think the stent is going to override? But, you know,
I mean, it has to override.
it has to.
otherwise,
There's no question. But I mean, in our experiences, you know, we've done a lot.
Yeah,
really
that's
hasn't had a problem in that way. But I want to show you a few more things. Go scene minus, guys. So what I want to do is now play the IVUS of the left now, because now we got to start treating this. So if you play the IVUS on the left, now I want you to just play it. So here you can see the IVC coming, right? And then again, I'm going to repeat it for the audience. And then you're going to see the stenosis starting and the iliac artery. You're going to see the override of the iliac artery very, very soon. So this is what IVUS did for us to diagnose this problem. So right here,
it is a very good test because with all the flattening, you cannot know angiographically.
Right. Exactly.
But
So,
here, you know the stenosis, and you were able to see that was exactly happening at the beginning of L5.
right.
So
So
you
now,
have a very good fluoroscopic mark as well.
exactly, and that's what I want to get to, George. Thank you for bringing that up. If you see it right here, so what we did was we went ahead and did IVUS, go scene minus 3, guys. So we went scene minus times 3, and we said, let's get the proximal area where we want to start the stent. Go again. Plus, scene plus. So this is where we're in the IVC, and I'm going to repeat it live again. This is kind of the beginning of the stenosis.
That's right.
Okay, go next. And this is the end of the stenosis. Now go plus again.
Exactly.
So go plus again. So no, minus. I'm so sorry. So minus 2.
So we need to start from the
Right,
beginning
no,
of
one
the
more.
L5.
So right here,
We
you're
need to
around
cover that.
L5. So you figure if the marker is put on by us in a very odd manner. I don't know why it got put on like this, but you can see here that approximately it's around the number
Well,
6.
you have the vertebral.
Around number 6, right? And then go forward. Can somebody straighten this marker, please? I mean, you can't measure anything on this. I mean, because I want to show how to measure and we'll repeat the IVUS one more time. Put it straight, Ricky. Can I fluoro for a
Looks
second,
like
Ricky?
we have for sure
Just 1
7
second.
or 8.
Yeah, that's perfect, like that. So now you can see Ricardo, our great tech, has put it properly. So what we're going to do is we're going to go up
From
again.
9 to 15. So
Let's do it one more time, George, because I think this is important.
Yeah, let's do it
on,
live.
on how to stand. Go live, guys. So we're going to go into the IVUS again, into the vein again, and I'm just going to pull back here. Okay, so show IVUS and angiography. Thank you. So as I see the vein, I'm going to fluoro and keep pulling back.
Yeah,
And I'm going to tell you, and you guys tell me where the stenosis starts.
Not yet. The artery is big. Now the artery
Now
starts
it starts
coming
to
now.
come.
Right now starts
And-
to already develop.
So
a little
it's
bit.
exactly where
Right.
George is talking, right?
The upper border of L5.
So that's the first one, upper border of L5. So you know you have to hang it proximally to this. All right, and then you're going to keep coming, and I'm just going to keep pulling on both.
Yeah.
Okay,
It's already relieved, but
but not totally.
not totally.
Right, it's still compressed. There, see, you see that point right here? You
Still
can see
there.
the central compression.
Yeah, there's a jump.
I'm going to go forward. See that
Yeah,
right there?
I think it is relieved, and then you have a secondary compression
Right.
from the
Little more
dam.
Right.
So
distal.
you still need to go a little distal.
Right.
Right
Right there,
here.
right
This
there,
is-
And
probably.
right here, probably around 15, you're completely relieved.
Exactly.
Right at the
Okay?
pelvic brim.
So if you think about it, go
Can we,
plus,
can
go
we
minus,
zoom on
please.
the angio?
So you see here, you're starting here.
Yeah.
So you're starting at, like you said, George, the
Seven.
fifth, the vertebrae, whatever it
Right.
is, and coming all the way, so that's around 8 or 7. Go next. And then you're ending around 15. So that's already 8. So so the question is whether we should use we have a 90 millimeter stent. So we have a 90 millimeter stent. We have an 18090. So we can use 2 stents. So the whole point is our plan here is you use an 18090. So now you can say, why did we use an 18?
So
Sinan?
yeah, you want to use an 18? What type of stent exactly you will use?
We're going
Wall
to use a wall stent. As you know, I know Dr. Guja talked about
Oh,
the problems with iliac vein stenting. Well, what type of stent would be ideal, Karthik?
So I think the ideal thing would be to put a wall stent, because wall stent has the most amount of, you can say, radial strength. That's probably not the right word to say, but radial strength is probably technically understandable. Any other stent you put, even a covered stent you put in iliac veins, because the compression, there's going to be significant amount of compression and sometimes fractures. So I think wall stent has the best amount of radial strength. At least currently in the market right
How
now.
you deal with the wall stent jumping proximal distal?
So traditionally, I think there are some papers comparing direct iliac vein stenting versus IVC stenting into the iliac vein. So I think it's been shown very clearly that you start in the IVC, you start deploying the
Give me a
stent in the
give me
IVC.
a
You want to go
pigtail
at least 2 to 3 centimeters into the IVC and then deploy the stent. So wall stent after ballooning, after you deploy, once you balloon, is shown to foreshorten a little bit. So
Yeah,
you
that's on
expect
the
a
side.
foreshortening of about 5 to 10%. So if you're taking a 90 stent, you're expecting it to be 80. So I think 90 is I think 80 is the longest we have.
90 is a long
90 is
time.
the
90 is the
longest we
longest,
have. So I think we'll probably go with the 1890 and I guess stent it. So but you have to deploy it into the IVC.
So George, what we're going to do to make it a little bit more fun is I'm going to put a pigtail into the right iliac vein.
Yeah.
And I'm going to inject. Just, listen, everybody needs to understand these are those things that are kind of weird and difficult to understand.
Well, you have to also be concerned that this stent is not going to close the right side.
Well, it generally doesn't, as you know. But
but
what I
because
want
it's
to
a
do
little
is more
compressed,
for
what I'm saying, there's already a compression.
understanding where the ostium is. So
So-
I want to leave it right there, right?
So
Pull the
So,
pigtail up.
so I'm assuming, are you going to fix the right side as well, or just leave the right as
Well,
well?
that's going to be the second discussion, Vishal, because I think we're going to be very opinionated on that. So what I'm going to do is come forward, please, give me 20 cc's. So what I want to do now is inject in both, and I want you guys to go a little forward. Mag up on the distal, guys, mag up on like 15. So what I want to do here, guys, is do a DSA run in this level. Let me see where we are.
You'll probably pull the pigtail a little bit back.
I am going to pull it back, George. You're absolutely right. Actually, this may not be bad, George.
that's probably a good idea.
Probably good. Go higher.
It's probably a good spot.
Yeah, this is probably a good spot. See right here? That seems to be
Yeah,
where
but
they were right. We'll keep it right here. All right, so let's do a DSA. You guys inject through this. I'm going to inject through this. Just inject. Ready? Sir, deep breath in. Let it all the way out, and don't breathe. When I tell you to inject, inject. Inject. Okay.
So it's still higher.
Okay, so
Sorry.
you kind of have now what I want you to see is, again, don't get fooled. If you look, one is flattened and the other is tubular. So remember, it's likely higher than this.
Yes.
Okay, that's what I want you. I don't want you to get fooled, because if you see, there's an
Yeah.
overriding
There's an
of the vena
overlap.
cava.
I think it is exactly where the
Exactly,
tail of the
George.
pigtail
And,
is.
and that's what I want to show. I want everybody to understand that in this situation, you cannot go angiographically.
Right.
And so you really need to trust your IVUS and what you're doing. So I'm gonna do one more view, okay, and I'm gonna move it up. I'm just gonna go a little bit more lateral, and I'm just gonna move it up a little bit, right? I'm gonna go right here.
Yeah.
Let me put it right here, and I want to, maybe we can show it even better. Give me some dye, guys, so I can
Probably
inject.
put around 2 or 3 and then inject.
Can
Yeah.
you show a little bit the numbers there? So we can,
Yeah, I will.
Yeah,
Go,
yeah,
go
right.
one mag lower, guys, here. Yeah. Okay, right there. Okay.
You want to go a little more lateral?
Go a little more lateral if you want. That's fine. All right, we got to see the numbers though. All right, ready? One last time. Sir, let it breathe normally. Deep breath in. Let it all the way out, and don't breathe. Inject. That didn't show too well, but you get the general gist.
Yes.
Okay, so I think now we're going to start deploying the stent. I'm going to let Dr. Guja obviously to do this. And
Well, I think it is exactly at between 5 and 6 because you see how there's a double border that happens there. One belongs to one iliac, one
Exactly.
belongs to
I
the other
agree.
iliac. That's exactly
and
what
George, you can also see very clearly that we really need to start the stent from 4.
from 4 or 5.
4
yeah.
or 3 even.
4. I would probably go from 3 and then go down because it's going to shorten anyway, so you could pull it back and then
Right, exactly.
deploy it.
So go AP guys for me. And put me on regular corner. Just go AP so you can work on the measurements you had
Yeah,
before.
exactly.
Uh-huh.
So you're using an 18090?
Yeah.
18090. And right there. I'm going to pull the pigtail back now. Get it out of the way.
So just for the sizing for people, how do you really size it? Do you
So
go-
look, let's, before we say anything, Vishal, I just want to confirm for Karthik's sake. So I want to make sure, again, when you're standing these, you want to do a nice job, and and I'm going to go back to our measurements that we talked about. So here's the, okay, so sorry. We got to go plus. So this is the proximal, right? And
Yes.
this is the distal. So the proximal was around 6 or 7, like we talked about. So we're going to start from 5, right? Just as we talked. And the distal is around 15. So now we are using a 90 stent, so Karthik can even go a little higher if he wants, flower it and pull it back. You agree with me, guys?
Yeah.
Yeah.
Yeah, that's fine.
Right?
Yeah.
I agree. But you got to pull it back like we talked about. And George and I
Okay,
like
that's
it.
good,
Like
that's
it.
good.
That's
Like
good.
it. Yeah, exactly. That's why George and I love it. Now remember, stop there for a second. What's the matter?
Srinivas, I'll talk to you.
So let's talk a little bit about the point of no return, Karthik. So
Yeah.
right now you can still recapture the stent.
That's
You
right.
still return.
Yes. So
Still
this is
return.
where you want to place it. So
I
what do
think
you,
this is a good spot.
I like
You
this
want
spot
to
too.
inject from the pigtail? You can if you want.
I will definitely do that now.
What do you think, Dr. Dangus? This is a good spot?
I think it's a good spot.
We
I
all-
just
we
want to
all
make it a
like
little
it.
bit more educational by the various injections there. We have
So
the
I think we
pigtail
are like
anyhow.
3 centimeters into the IVC, which is so it causes a little bit of foreshortening, but we'll be okay. I think that's a good spot.
I like it. George?
Yeah, it's good.
I really
it
like it.
shortens a little bit. It's okay, so it's good.
No, but remember, you see he's totally in the IVC there, which is what you want to be.
Yeah, I know. Even if
Yep.
it shortens, so it's good.
Yep, and now he can pull it back if he needs to. But right now, let's flare it. Okay, let me pull this pigtail back a little bit. Sorry, forgive my
It's
hands.
okay, no problem.
There you go. Uh-huh.
I think the IVC is so big, we should be fine.
Still it with a return point, but
Yep.
soon coming
Still
to the
there.
no return.
Okay, now pull back a little.
I think
There
we're
you
good.
go. That I like.
It's okay. It's going to shorten. You're going to observe how it shortens from the bottom now. The bottom is at 18 now. Let's see where it ends up.
And it's going to tilt with the IVC. Yep. See?
There you go.
Good.
Beautiful.
Very good.
Now let's get an IVUS.
Let's do an injection from the right.
Mm-hmm. Ready to inject? Put me on DSA, guys.
To a bilateral.
Ready? Ready?
Yeah. Nice.
You're in the
Beautiful. Now we got a good picture.
Okay, now guys, this is, people get crazy about, oh, I'm overriding the IVC. Don't get crazy about that. It's okay. You're fine. So let's do another IVUS here.
So I think, Dr. Dangus, there's a lot of data which shows, right, that if you stent into the IVC,
The patent
actually it's
is
more
that.
safer than just doing the right iliac, knuckling the iliac right at the ostium. So the IVC is so big. They say, I don't know if, do you think stenting the IVC will give a problem in the right?
No, not in this
I
case. You
personally,
can
I
see
personally
this is
don't
a
think
smaller,
so. I don't think
this is
PK
a
thinks so
smaller,
either. I don't think that
diameter
should be
vessel.
the reason to stent the right. And I think I agree with PK that.
All right, so we're starting in the IVC now, and I'm going to pull back both, right?
Beautiful. Now this way we're going to see the bifurcation also. Let's see. Coming up. Still,
That's
this
your
is a stent. You
So
can
you see
see
there's a
how
lot of room
there's
on the
flow
IVC.
around it. This is a
There's a
bifurcation.
There you go. You see that,
Actually
guys?
at like 7.
Absolutely perfect. Look at that.
This is great now. There's
Look
no,
at that. You
no
see that now, guys?
compression. Very good. Let's go to the secondary lesion.
And now we're
beautiful.
1 to 1 right there.
Absolutely.
There is
Right?
no
Yeah, 1 to 1.
problem.
And we're done.
That's it.
Okay, great.
Right.
So the only question here is what now we need to concentrate on the opposite side.
Yeah, I don't know about that.
You post, PK?
I don't think there's anything to
You're
do
getting
there.
pain in the back?
Okay. I guess
Where
it
in the back?
depends on the.
I'm not too excited about the right, but
Cycle a cuff?
what happened? Patient became a little vagal?
He's having a little pain in the back. Just want to make sure our wires are okay. We had no problem. I mean, Ray hit. We got a couple of shots into the artery when we went in. I want to make sure there's no retro or anything like that. But right now, so you saw this is done. Now the question is on the right. Are we excited about the right? Let's talk about the pros and cons of stenting the right. And what do you think?
Well, I guess it all depends. I mean, the clinical presentation is there. The area is almost 50%. So
Yeah.
it's mainly it would be a clinical decision right now to see if we've done everything, the GSV is closed.
Pressure is
If you
fine.
think that's what's causing it, then I would go ahead and just stent it.
Yeah, well, I'm not excited.
So
See, I think George and I think I'm like George, and
I'm not
unfortunately
excited.
George and I don't know fully the clinical presentation the way Karthik does.
Yeah, I know. Karthik was late because of the traffic. So tell us a little bit about that story.
Dr.
Is the
Dr.
patient
Dr.
getting these
Manhattan.
DVTs
Dr.
because of the
Dr.
traffic also?
Manhattan.
Is that the problem here?
You know, I have to come from Long Island, so it's a long drive. So sorry.
So anyway, so that now the issue is, what are we going to do, Dr. Guja? You know the syndrome.
So I personally
do
think
what
Dr.
you think
Daniel
is-
says, see, he had 2 ablations before. I think my personal opinion is,
Can you rub it? Does it
Your
feel
personal
better if you rub
opinion is stopped.
so I
Now we're
think
gonna start.
if because of
commercial
I think before his ablations, the iliac vein stenosis should have been addressed, because if you are saying that we're going to treat him for chronic venous insufficiency, how are you going to treat his venous insufficiency when you know that there is going to be an iliac stenosis, right?
It's a lot better.
So
that's what I'm saying. It's all mainly driven
So
by
my
clinical.
personal opinion is, I mean, subjecting him to ablations for superficial venous insufficiency doesn't make sense
When did it
when
start?
somebody has an iliac vein stenosis.
When we deploy the stent. There's expansion.
So what
So this is also something that's interesting. The patient has developed back pain the moment we deployed the stent, and part of that is maybe the irritation,
stretching.
and stretching of the vessel and the nerves. So right now hemodynamically he's perfectly stable. So and like I said, matter of fact, this guy could have taken a 20 stent by our measurements. We
Yeah.
went with an 18, which is again maybe 2 millimeters oversized, and they recommend even a little bit bigger than that just to prevent embolization of the stent. So right now I want you guys to understand that what you need at this stage: check hemodynamics, do the bladder thing, usually make sure there's no shift, check your wire position, make sure you haven't perfed a kidney or anything like that if you use glide wires. And then at this stage now, since I missed the conversation, I'm assuming that Dr. Guja's decided to stent it, so we will go ahead and use IVUS guidance to go ahead and stent it. So
What
can
do
I
you
have a
think?
035 wire? Is that better? When it's rubbed, it's better. Okay, good.
So your stent
So-
of choice still remains the same, or you switch over to because here you're not suspecting compression as being a cause on the right side.
Well, that's a great point here, but I think what's important here is to use IVUS and the same kind of markers that we did to see where to start, where to end. I think that's the key here. So the question is, where do you start the stent, where do you end the stent, and also sizing of the stent.
go away.
I think
Just
our IVUS expert says it's going to be around a 16, right, on the right? 16 or so on the right. So I think what we'll do is
Came
we're
out
just
very
going
nice.
to
You
pull
don't
this
have to build on
back,
it. You don't even have to build on
and
it.
then we're going to
Just
go
open it.
ahead and
I'll talk to you more when you go
get
out,
this
okay?
wire up. We're going to IVUS one more time. Okay,
You
good.
see how easy the wire goes through? I mean, again, I want to point out to the viewers that the stent is circular
fine.
into the IVC, and the IVC is wider than the stent in all
it
dimensions.
excruciating?
So the wire goes all the way around the stent without a problem. And particularly in this case, he crossed with a J
Very
tip
uncomfortable. Huh?
uh,
This is
with
interesting.
the
Okay,
wire,
we'll
which
see.
then
We'll make sure.
buckled up all the way, so you know it did not go straight through a strut. That's another good
12.
technique.
Again?
The issue of the back pain may also be because the stent now is pushing on the iliac artery,
That's
Yes,
right.
sir.
which is
That's
right on
right.
top of it, and therefore you have some other kind of, or maybe even nerves that go there.
So we have an interesting condition here because the MR visualized this around 14. Our IVUS is giving 16, so we may not be able to stent it because we don't have another 18 stent here. You can start from there, guys. So you can see that's the IVC with it overriding into the IVC.
Yeah.
Right.
And now fluoro. And we're going to pull back.
That's the bifurcation.
That's the
there.
bifurcation.
That's a bifurcation.
So
That's your
probably
arc.
we need to start where? Here at 14?
Keep coming.
I don't know. I'm not so convinced here.
There.
Right there.
Right there, it's around
Keep
17.
coming. Keep coming. Yep.
And then it's opening up.
I don't know. It's kind of never ending. Where did it end? Here at 20 maybe?
There.
Maybe we can stand between 15 and 20.
I
20.
think so.
I just want to do a DSA of the other vein just to make sure nothing crazy happened. So
Yeah, I
the
don't
argument.
know.
So let's
Better?
measure that right now, guys. Come forward.
Is it getting better?
Okay. Deep breath in.
Just nagging.
Sir, deep breath in. Let it all the way out, and don't breathe. Go ahead.
Well, nothing crazy
Looks
has
good.
happened.
Nothing bad. You know, a little bowel gas underneath and all that, but nothing major. So I think right now, we'll take one more lateral view just to make sure that we're not missing anything. Deep breath in.
No, I think I would.
Let it all the way out. Don't breathe.
It's a fair call, like I said.
Again, nothing crazy.
This stand is only stuck at
So
the
I think the bottom line here is that this is just like Dr. Danga said, compression of the artery on irritation of the nerve, so on and so forth, and it should resolve.
I think Dr. Dangus, I've seen it before. When after we put the wall stent,
Yeah.
sometimes patients have back discomfort.
Use a 16.
I think
right?
it's because the stretching, the artery is trying to compress, and the stent is trying to like stresses that compression. So I think if you give them, as long as the hemodynamic is stable, you give them like a couple of minutes of time, I think they'll start getting used to it.
So now we've remeasured, we've looked at everything carefully, and what it's looking. Can you go back to the IVUS, please, to show us the IVUS? You can see distal, as so nicely labeled, is around a 14 max, and then proximally, which is going to be labeled in a second, the normal to normal landing zone, which is that's the compression, right? Maybe a little higher than that. That's the compression. Okay, that's good right there. Try that. Because you want to stay out of the IBC, is going to be around, again, 14. So we're probably going to go with a 16 millimeter stent. And the issue is, I think
What
we
are
have
the dimensions there, 1 and 2?
we have 160 and 16040. Right?
40, I think.
Only 60. So we're going to go 16060.
60.
Again, I want to implore the audience that this is something that is clearly a clinical decision. I think if you see iliac vein stenosis of 50%, doesn't mean they all get stents. And again, like George very clearly said, it's just a tubular sort of stenosis, maybe a little bit of scar tissue. IVUS didn't show any thrombus. Obviously, Dr. Guja follows the patient. He has the knowledge base in terms of why this is clinically indicated. The left side, there's absolutely no doubt. I mean, we had the clinical syndrome, we had the compression, we had all of the above here to be treated. But the take-home point is, when you start to have these type of venous reflux issues, look proximally, because this patient actually went reverse. He had ablation first, and then went to Dr. Gujo without relief of symptoms, and then had the proximal workup done. So I think it's always important to look proximally first, and then decide. So this one, since we know what it is, we know now where the IVC is, what we're going to do is we'll probably just do this on a road map. Karthik, you agree?
Yeah, I think so.
So Flora, please. Okay, road map, please.
Yeah, I'm connecting.
Okay, he's going to cut. So what we're going to do is I'm going to let Dr. Good just start this. I think we'll just continue the discussion with George and Vishal. As far as anticoagulation is concerned, go ahead. Okay. Ready? Oh, sorry. Okay. As far as anticoagulation is concerned, what are your thoughts, George?
I think this patient will need oral anticoagulation.
Okay. I know it's uncontrolled. Just keep.
So you want to give him Plavix and an anticoagulant, that would be good.
Well, that's the interesting thing. Look, now it's even hard to tell where the stenosis is. That's the issue here. So let's go back with the IVUS again. And just let's do a DSA. Tell him to take a deep breath in.
So let's take a deep breath and hold.
Hold.
Take a deep breath. Hold.
This is what I'm saying. It's so dynamic. You know, he's gotten dye, so there's expansion of the vein, right? I think we should hold off here.
I think so. I agree. I think we should.
I guess
Breathe normally.
the learning point is vein is typically not circular, so sometimes very hard to ascertain whether the tubular or the change in dimensions is purely based on the
See,
architecture.
that's what I'm
or it's because
saying.
of the
See,
lesion
I
itself.
think I think that's where the IVUS is so
Yeah.
helpful.
I think
you know?
we can go with a 60 if we decide to go. So we're,
think-
you know,
But
we're
George, I
covered.
think
I think
in
we
this
just do.
one, a couple of gray hairs on our head helped here, because clearly, I think that this is one of those where you could leave alone, let him see how his symptoms resolve,
I agree.
and then decide. Yes, we have a 50% diameter stenosis. So be it. And what we'll do
We'll
is
reevaluate.
we'll reevaluate.
Yeah, I think that's probably the wiser in order to also see what your left thing did for the
The
left
right.
leg
Yeah.
and understand how things go. And now
And
you
George-
have a comparison.
And George, I got to take it back. You don't have gray hairs on your head.
Dr. Dangus, you're about there. So
Well, listen,
That's
guys.
a good
I
point,
want
is
to.
because I don't have a lot of traffic coming to work.
actually, you know what? With this traffic, I might get it faster than you.
Yeah, that's what I'm implying, Karthik. That's why you're wearing this thick hat.
So, Dr. Dangus, I think I agree. I think we can always stent him if it's necessary. I think to take it back is the problem. So, I think I can clinically follow him and see if he still has symptoms. I can always bring him back.
So I think in conclusion, I just want to do a quick wrap up here and just go over some of the points. First of all, I want to thank Dr. Jain for that great discussion. I think one more time we should IVUS the opposite side, the left.
Yeah, yeah.
So one is, first and foremost, is when you're dealing with a patient with superficial venous symptoms, you need to look at the deep veins. You need to go back. You need to make sure that there's nothing deep going on. As Dr. Jain so eloquently said, 25% of the population has this sort of iliac vein compression syndrome, and not all of them present typically. So the typical presentation may be what we're looking for, a female, pregnancy, so on and so forth, but the bottom line is you also want to make sure that you have this in your differential. So second, once you look at the proximal veins and you've identified the stenosis, you need to figure out, well, what is the gold standard, right? So Dr. Jain clearly said that MR seems to be the gold standard at this stage, but I have firmly believed, I don't know about you and Dr. Kapoor, Dr. Dangus, that intravascular ultrasound is truly the gold standard. If you have a high degree of suspicion, bring the patient back in. I just want to make sure it's 1-to-1 distal, or we need to put another stent. What's it called? So the issue is, you want to make sure that you have an accurate diagnosis. Then second is we demonstrated very clearly the utility of intravascular ultrasound in identifying where to start the stent and where to end the stent, and also how to measure. So I think those are the key. Lastly, the procedure itself for most interventionalists is technically non-challenging, other than understanding the ultrasound and landing the stent properly and sizing the stent properly. But here you saw a clear illustration of how what looks like a significant stenosis may not be. You could see here dynamically, we gave about 150 of dye in our demonstration in a patient with normal creatinine. Blood volume went up, and therefore, you can see the iliac vein compression also, or tubular stenosis also seemed to resolve. So you need to put the clinical picture together with a proper algorithmic diagnosis and procedural diagnosis leading to the proper procedure for this particular type of patient. Interestingly, you also saw one of the issues that can happen, which is pain, and we explained it as Dr. Dangus so nicely said, compression of the iliac artery, irritation of the nerves, so on and so forth. The question of anticoagulation is very controversial here. So I think what we're going to do is, there are no guidelines or recommendations.
I wouldn't.
As far as I know. So is there anything that I missed, Sachin? No. So I think what we're going to do is we're going to follow our usual, like Dr. Dangus said, with dual antiplatelet therapy, and then see how this gentleman does. So I thank all of you. I thank Liz. I thank Ricky. I thank our team, and especially Dr. Guja for this wonderful case. Dr. Jain, thanks, George, and we'll sign off.
Thanks, Dr.
Thanks,
Dangus.
Vishal.
Thanks, Vishal.
Thank you.
Great, thank you. That was great. Don't you think? That
That was
a
an
great
amazing
case.
case. Good learning
It was a
case.
really great case. I'm glad we left that one for the future. Well, let's let everybody remind, if you join the transmission in the middle, you can go to archive, you can see this entire case, you can see past cases, and you can post more questions for us at the website, and we're going to answer them at the blog. That's what happens all the time. And if you reminder about the app, if you go to the App Store, CCVVC, and you can get the app for our live symposium of last June with more information as well on the live cases. And in addition, on October 9, Friday, we have a live symposium of the top 10 developments in interventional cardiology this past year. And that will be a great one to come and meet us and interact with all of us here at the Medical Center, Mount Sinai. The next webcast is arranged for October the 28th. At the same time, anywhere you may be around the world via the internet at 8 a.m. Time here in New York from the Mount Sinai Heart Cardiac Cath Labs. At this point, we'll close the transmission. Have a good day from Dr. Kapoor and myself here at the moderator's table.
Thank you and have a good night.